Greetings everyone, my name is Rick Lawson and I work at MCA. We're one of the oldest EMS and ambulance billing companies in America with nearly 3 decades of experience. Our discussion today will cover the top 10 most common documentation issues and the best ways to eliminate them. The EMS billing industry recognizes Medicare guidelines as the most comprehensive, and we will follow these guidelines throughout this presentation. It's critical that the PCS is completely filled out. It must include basic information such as patient name and date of transport. You need to be clear about the necessity of ambulance transport versus other means. Additionally, the PCS cannot stand alone. Your run sheet documentation must be complete as well. Repetitive ambulance trips may be scheduled or unscheduled. These are defined as medically necessary ambulance transportation that is furnished 3 or more times during a 10-day period or at least once per week for a minimum of 3 weeks. 2 examples of treatments that qualify for repetitive trips are dialysis and respiratory therapy. PCS forms for repetitive patients must be signed by a doctor before repetitive or scheduled transports occur and are only good for 60 days from the date of signature. For non-emergency unscheduled ambulance services and non-emergency scheduled or non-repetitive ambulance services, the ambulance supplier must obtain a PCS prior to claim submission. The PCS, however, can be procured up to 48 hours after the service has been provided. If the ambulance provider is unable to obtain a signed PCS from the attending physician, one can be signed by a physician's assistant, a nurse practitioner, clinical nurse specialist, registered nurse, or a discharge planner, as long as one of these individuals has knowledge of the patient's condition at the time the service was rendered. Your narrative has to answer the question, why did the patient need ambulance transport and care provided by EMTs? If the only possible safe mode of transport for the patient is via ambulance, you must describe the circumstances clearly and completely in the narrative section. Some examples include relevant information about the patient's condition and weight, equipment needs that only the ambulance can provide, necessary meds, and any oxygen that the patient cannot provide on their own. The medical necessity standard is considered fulfilled by ambulance services when the patient's condition is such that he or she cannot be transported by any means other than the one provided without endangering the patient's health. Simply stating patient is bed confined is inadequate. You must document why the patient is bedridden. An example of this would be, quote, patient is non-ambulatory due to prior CVA and is unable to maintain an erect position for duration of the trip due to paralysis down left side, unquote. In general, Medicare will cover non-emergency ambulance services when it is documented that the patient was bed confined before and after the service was rendered. Medicare defines bed confined as unable to get up from bed without assistance, unable to ambulate, unable to sit in a chair or wheelchair, requiring a stretcher, or requiring restraint to prevent injury to the patient or others. Other medically necessary justifications for ambulance transport include the patient must remain immobile due to possible fracture or an unset fracture. Patient needs advanced airway management. The patient requires non-self-administered IV meds en route. The patient requires chemical restraint. Patient requires airway control or positioning en route. The patient requires assistance to apply, administer, or regulate oxygen en route. The patient risks injury during vehicle movement despite restraints due to their condition. Patient is morbidly obese. Patient has a communicable disease or hazardous material exposure. Patient has an orthopedic device that requires special handling, such as a backboard or halo retraction. The patient has severe pain aggravated by transfers or a moving vehicle. Patient requires special handling and positioning to avoid further injury. And the patient requires special handling and positioning that cannot occur in a wheelchair or standard car seat due to contractures or extremity fractures such as post-op hip surgery. In order for a run to be billed as an ALS run, you must document that a paramedic assessed the patient and their condition at the time of dispatch and that these factors required the use of a paramedic. If this is not the case, then the run is not considered ALS. The ALS intervention is a procedure that is in accordance with state and local laws and required to be performed by an EMT intermediate or a paramedic. For example, 911 dispatches with patient complaining of chest pains. When your crew arrives, the patient states the pain began after eating chili. ALS assessment performed due to complaint at dispatch, but the patient is actually transported BLS to the hospital. Medicare defines emergency response as a BLS or ALS level of service that has been provided in immediate response to a 911 call or the equivalent. An immediate response is one in which the ambulance provider begins immediately to take the necessary steps to respond to a call. Some questions that need to be answered are, why was the patient dispatched through a 911 center or the equivalent? Why was the ambulance dispatched? What was the complaint at dispatch? This information is critical in considering a run billed as an emergency. The documentation on the run sheet needs to clearly state how the squad was dispatched, and it must include the date of transport, the patient's name, the patient's date of birth and age, the patient's location, the patient's address, the chief complaint, and a brief medical history. This occurs when the patient is transported ALS, but the documentation does not meet your state's ALS standards. The treatment must be clearly marked or added to the narrative in order to bill the proper level of service. The HCPCS and ICD-9 codes reported on the insurance claim must be supported by the documentation on the run sheet. This includes documentation of procedures and supplies provided, such as drug therapy, administration of emergency oxygen, IV therapy, restraints, CPR, intubation, and cardiac monitoring. Medicare requires a patient's signature for each transport in Section 1 of the signature sheet. If a patient is unable to sign the run sheet, the reason must be clearly documented. If someone else is signing in lieu of the patient, this also must be clearly documented in Section 2. Those authorized to sign for the patient in this instance include the patient's legal guardian, the patient's healthcare power of attorney, a relative or other person who receives government benefits on behalf of the patient, a relative or other person who arranges treatment or handles patient affairs, a representative of an agency or institution that furnished care, services, or assistance to the patient. A crew member cannot sign in Section 2. If the patient is physically or mentally incapable of signing the signature sheet, and there's no authorized representative available or willing to sign on the patient's behalf, Medicare requires that Section 3 must be completed by a crew member or a hospital representative, or you can obtain a face sheet with a date and time stamp of admission prior to submitting the claim. This documentation generally answers the question, how was the patient found? Were they in bed? Were the bed rails up? Were they seated or standing? If a patient can physically make their way to the ambulance, you need to include specific documentation regarding the details and circumstance that reinforce the necessity of ambulance transportation. For example, if the patient is found in a chair, what type of chair? Is it a geriatric chair or a wheelchair? Was the patient strapped in? These are the kinds of specifics that are imperative in your documentation. Some of the state-managed care organizations require a physician assistance request prior to transport. In these instances, you need to make sure that the proper paperwork has been completed, submitted, and authorized. Your documentation needs to answer the following questions. Why was the patient transported from one hospital to another? What services does the transfer hospital provide that the origination hospital could not? Documentation must indicate the patient was discharged from the origin hospital and admitted to the destination hospital. The specific services that were not available at the first hospital must also be documented. Non-specific or vague statements such as needs cardiac care are insufficient. Thank you for your time. I hope you've found this information useful. Please feel free to contact us at info@mcabilling.com with your questions and comments. Also, if you feel that others would benefit from this information, please share this presentation via email, Facebook, Twitter, or LinkedIn. Thanks again.